Welcome to the module on assessing an incident, the primary survey, CPR and secondary survey. This is a really simple process that first aiders can follow to ensure that they don't rush in and make a mistake in terms of the first aid that they administer, or probably even more importantly, they don't rush in and put themselves in danger. So it's important that you look. So what can you see round about you that might give you an indication as to what's happened to the casualty? Listen to the casualty themselves and what they're reporting to you, or to what bystanders are saying. Pause and have a wee think about all of that. So what are you faced with? What are the likely injuries or illnesses that the casualty is suffering from? What might you do about that in terms of your first aid treatment? And then act. And this should ensure that you don't rush in, as I said, and either make a mistake or put yourself in danger. So if we've already mentioned in one of the other modules, the primary survey establishes if there's any life-threatening conditions to the casualty. So life-threatening condition is something that compromises either the casualty's airway, their breathing or their circulation. The doctor's ABC is a process that first aiders can follow, and it doesn't really matter what the incident is that you come across, you can always follow this process. You're just hoping that you're not going down to the bottom two, so CPR and having to use a defibrillator, because things aren't generally very good for your casualty at that point, and let's face it, they're not very good for you if you're having to administer CPR to somebody. So what are the dangers? What dangers are you likely to face in the context that you work in? So if you're a football coach, for example, and you're having to run onto a football pitch, then other players, underfoot conditions, etc. How can you assess for a response in your casualty? Well, the easiest way is to speak to your casualty. If they respond and they talk back to you, you know that they're breathing. And once your casualty's talking, keep them talking. As long as they're talking, you know that they're still breathing. When they stop responding or talking to you, that's when you need to start to worry. At this point, you're going to shout for help, so that's just getting somebody else, another competent person there who may be of assistance further down the line. You then need to check the airway in the casualty, so you're going to do what's known as a head tilt chin lift. So you're going to place one hand on the forehead of the casualty, the other hand under the chin, and you're going to tilt the head back to open up the airway. And the reason we're doing that is just to give the casualty the best possible chance of being able to breathe. We're then going to assess for breathing, and we're going to do this by placing our hands on the chest wall of the casualty. So we'll show you how to do this on the practical day that you come on. That's the most effective way to check for breathing. You might have been told previously to look, listen and feel, so you look along the line of the chest, you feel for breath on the side of your face and see if you can hear the casualty breathing. In the majority of workplace contexts, this is going to be extremely difficult to do, and in a sports context, all we feel on the side of our face in Scotland is generally the wind and the rain. So by placing our hands on the chest wall, rib cage of the casualty, we should be able to feel movement and establish whether the casualty is breathing or not. We want to do this for up to 10 seconds, so a minimum of 5 seconds, but no more than 10 seconds. We should have felt at least one breath in those 10 seconds. If we haven't, the casualty is either not breathing or not breathing adequately, both of which we need to intervene for. And at that point, we're going to start administering CPR while asking the person who we shouted on and asked to stand by to then phone for an ambulance. They're going to state that the casualty is unconscious, not breathing, and give the address and postcode of the venue and come back and let you know that they've done that. And we're also going to send somebody to go and get a defibrillator if there's one available, so generally in the reception area of most workplaces, or if we're in a shopping centre, it will be the concierge office. Again, we've already seen this slide in a previous module, so it just highlights that our role as first aiders is really important. We can do at least the first 2 bits in the chain there, potentially the first 3 if we have access to a defibrillator, and that's really, really important to give the casualty the best chance of surviving and then be able to receive post-resuscitation care in hospital or by paramedics on the way to hospital. This side looks complicated, but it's not really. So just think about perfusion pressure as the amount of blood and oxygen that we get to the brain. If we do the best possible depth and rate of compressions, then we get a consistent flow of blood and oxygen to the brain. As soon as we stop our compressions to do our rescue breaths, then blood pressure drops and the delivery of blood and oxygen to the brain drops. And when we start our next lot of compressions again, it takes a wee bit of time for that consistent flow of blood and oxygen to get back up to the optimum level. So that would suggest if we are prepared to do a rescue breath, we should be effective and efficient with these. So we're going to breathe into the casualty's mouth for a second, turn our head to the side for a second, breathe in for a second, and then immediately start with our next set of compressions. We're not going to check for signs of life because in an adult casualty it's extremely unlikely that there will be any. The only thing that's going to restore normal heart function is our defibrillator. In an adult casualty, 9 times out of 10 it will be a cardiac related issue, so a heart related problem. So the heart pumps blood and oxygen around the body. If there's a cardiac related issue, then that pump isn't working properly, so we start with our 30 compressions. After 30 compressions, a bit of time's passed and we've used up some of that residual oxygen that's within the system, so we need to breathe into the casualty's mouth twice to add additional oxygen into the system, and then start with our next lot of compressions to pump that oxygenated blood around to the vital organs, particularly the brain. If the brain's starved of oxygen for even as little as 2 to 3 minutes, there's potential for irreversible brain damage. Not to say that there will be, but there's potential for. We should be looking to achieve a rate of 120 compressions per minute, so that's 2 a second. It's quick, and we want to achieve a depth of 5 to 6 centimetres. So there's a few reasons why we would stop CPR. So if somebody better trained arrives and takes over, so for example the paramedics might arrive and instruct us to stop. If we become exhausted and we feel we can't continue, if the casualty shows signs of life, so signs of recovery, so things like moving their arms, talking, they'll start to swallow again, opening their eyes. If we see any of those, then we're within our rights to then stop CPR. Obviously in an emergency situation, then hopefully adrenaline's going to be flowing, and that will enable us to continue for as long as possible and do the best job we can for our casualty. So this slide just highlights that as time progresses we start to get tired, and our accuracy in terms of our rate and our depth of compression starts to decrease. So you can see there's a bit of a cliff edge after 3 minutes where we're only about 40% accurate. So the guidance is European Resuscitation Council guidelines are that we swap with somebody else who's first aid trained every 2 minutes, and that should enable us to maintain roughly about a 70% and above accuracy in terms of our rate and our depth of compression, and that's good enough for our casualty. If there's an automated external defibrillator available, then we should use that as soon as possible, so we should get somebody to get the AED or the defibrillator for us. If we can get the defib hooked up within about 1 to 3 minutes of the casualty requiring it, there's somewhere in the region of a 50 to about a 70% chance of survival, 75 on a very, very good day. The chance of survival drops by about 10 to 12% per subsequent minute of delay. However, if we do good quality CPR, then that 10 to 12% drop becomes only 3 to 4% per minute of delay. So we've bought our casualty a wee bit extra time for the paramedics to arrive with the defibrillator, and hopefully they're still going to be in what's known as a shockable rhythm. In other words, the defibrillator can bring the casualty back. When we phone for an ambulance, we want to think Lionel. So we give the location of the casualty, we describe the incident, so what's happened to the casualty. We need to state if we need other services, so for example fire brigade, police, etc. We state the number of casualties that we're dealing with, the extent of the injuries of those casualties, and we repeat the location again at the end to make 100% sure that the operator knows where to send the ambulance. Assuming we've assessed a casualty and done a primary survey and there's no immediate life-threatening conditions, we can then conduct what's known as a sample history. So that's collecting some further information on the casualty. So some signs and symptoms. So signs are things that we can see, symptoms are things that our casualty reports. So we must ask our casualty some questions to get the symptoms. Does the casualty have any allergies? Do they have any medication? Do they have a past history? So do they have chest pain and they've maybe had angina or something like that in the past? Their last meal or the last oral intake, and the event history, so what led to them needing your assistance as a first aider. If the casualty is unconscious and we're unable to gather our sample history, then we need to do what's known as a secondary survey. So this is a systematic check carried out when the casualty is non-responsive but they're breathing. So we check behind the skull, behind the ears, the face, the neck. We then work down onto the shoulders, clavicles, the chest, the rib. We then check underneath the armpits, we check the arms and hands, we then check the abdomen, the pelvis and the groin, we check the legs and the feet, and then we also roll the casualty into the recovery position to check the posterior aspects, so the aspects on the rear side, the back side of the casualty. We'll cover this as part of your practical day. Sometimes it's necessary for a first aider to determine what casualty needs assistance first, so the 4 B's in terms of the priorities of treatment. So we've got breathing, bleeding, burns and bones. Actually, the casualty who has a significant bleed, so known as an arterial bleed, is in need of our assistance first, because actually the casualty who's not breathing is essentially already clinically dead. If we don't deal with and stem the bleeding, then the bleeding casualty will end up in the same condition as the person who's not breathing. So in that situation, we have a difficult decision to make, where we approach and deal with the bleeding casualty first, stem bleeding, then we deal with the one who's not breathing. The burns and bones then depends on the type of context and environment that we work in. So in a sports context, for example, then bones would be our next priority in terms of fractures, and burns are less likely, so they would come after that. In an environment like a restaurant or a fast food chain, for example, then burns would probably come above bones because they're more likely to happen in that particular context. So as a summary, we'll deal with the significant bleeds first, anybody who's not breathing, and then the bones and burns will depend on the context of the environment of the workplace. It's really important as a first aider that we take observations, so the first set of observations becomes the baseline against which everything else is assessed. So we need to monitor something called BRPS, or burps without the U. So we monitor breathing, we monitor response, so we use something called the AVPU scale. Is our casualty A, alert? Are they V, responding to our voice? Are they P, responding to pain? Or are they unresponsive? And obviously the casualty who's unresponsive is in need of more assistance than the casualty who is A. We can look at pulse if we're trained to do so, but that can be difficult to detect, and it's not really something that we would suggest doing at this level of first aid. But we can look at the colour of the skin. So does the skin look blue to suggest that there's a lack of oxygenation, for example? So that's us come to the end of this module, just an opportunity for you to pause and reflect, maybe make a note of anything that you want to ask on your practical day, or again, you can post any questions that you have in the discussion forum